So if I can introduce our speakers. So we've got Karen Mead, who is a specialist transfusion practitioner within North Bristol NHS Trust and has been in this role for over 20 years. She is a BBTS Council member and was chair of the Transfusion Practitioner SIG from 2023 until the beginning of this year. Karen represents BBTS within the National Transfusion Practitioner Network and is a member of the steering group for the TP Professional Development Framework. And her partner in crime is Dr. Ruben Cooper. Ruben is a consultant in emergency medicine at North Bristol NHS Trust. He's a critical care director with Wiltshire and Bath Air Ambulance, where he is the blood transfusion lead. And Karen and Ruben are going to talk about pre-hospital, pre-transfusion samples, a wasted opportunity. So I think, Ruben, when you're ready, please take control of the slides and away you go.
Hello, everyone. My name is Ruben Cooper. I'm an emergency medicine consultant and critical care doctor with Wiltshire and Bath Air Ambulance. And as you heard from the intro, this is largely been put together through a lot of work from Karen that I've been supporting with. We'd like to talk to you about some work we've been doing in our area looking at pre-transfusion samples. We would like to talk to you a little bit about what it's like to be providing pre-hospital, blood transfusions. We'd like to talk about some of the challenges associated with that, the difficulties in and around pre-transfusion samples, and some work that we've been doing locally around that, and then share a little case study that highlights some of those areas. That case study is a description of an event that we've been to in the pre-hospital environment, and if you didn't want to hear about that, perhaps just turn your speakers off for that short period. I'll just let you know when that's going to be discussed later on in our talk. So whilst I talk to you about my service, just have a look at the picture and see if there's anything that you recognise from that picture. So I work with Wiltshire and Bath Air Ambulance. We operate 18 hours a day. We see about 1,200 patients a year. And that's one of the smaller groups of air ambulances in our region. But we see about a third of our patients are trauma, and of those we undertake a blood product transfusion in 40 to 50 patients a year, and that's usually a mixture of between 1 and 4 units of red blood cells or lyoplas. Occasionally, about 10% of the time, we give all of the blood products we carry, and we run a major hemorrhage protocol. Now, in terms of major hemorrhage protocol, the blood that we carry 2 units of red cells, and you probably recognise those in the yellow credo boxes circled in red, and 2 units of O negative blood. We carry 4 units of lyoplas in the other red circle, and then we carry 2 doses of calcium and a blood product warmer to try and manage any sort of coagulopathy associated with blood transfusion. And then we carry a blood administration pack and take pre-transfusion samples. The pre-transfusion samples are something that we aim to take, and I carry one on my leg pocket with the yellow arrow just to remind me of doing that, and we carry other ones within the pre-transfusion sample pack, which are part of the process that we undertake. We get our blood from North Bristol, and they provide us with the red cells and the pre-transfusion pack, which I'll talk to you about in a second. And it's a similar process that's undertaken by one of our local air ambulance charities as well, and is works in and around the region. Our blood administration pack might look familiar in places to you. So we have a pre-transfusion record, which is a place that we document our decision to transfuse. We describe the consent and we prescribe the products that are going to be used. We have a slight difference in the green box highlighted, which is an area that we can complete if a patient gets transferred to a hospital that's not North Bristol, so that we can link the patient records and keep that patient ID linked across, and also if a patient dies on scene, we're able to complete those details so that we can sort of identify where that blood was used. But I think what's really important to describe is actually how we use our patient identifiers. So we have some pre-made packs which have a first name surname made from a sort of a native phonetic alphabet type wording. We have a pre-made hospital number and a predetermined date of birth, and these are all individualized across the process, and we tend to issue one of those every few years, and we associate that with some stickers and some name bands, so we're able to positively match our patients on scene with a set of blood transfusion labels that can be sent with our pre-transfusion samples when we take those on scene, and they we carry more than one copy of more than one set of these in different places and in different areas of within our kit, so that we're able to provide more than one blood transfusion to different patients at the same scene, but with reducing the risk of cross-linking those details. So when everything is running well, we carry the blood products that we've described. But about 18 months ago, we suddenly had the description, and it was all very sudden, that we're running out of blood. And there were discussions around only having 1 or 2 days worth of blood supply left, and actually how would we manage as a service if there were no blood products available. And actually what we did at that point was that we reviewed our major hemorrhage protocol, and we reviewed that to consider actually what can we do to reduce our blood products usage, and we undertook procedures like changing our transfusion thresholds, maybe accepting people to have slightly lower blood pressures than we would ordinarily transfuse. We tightened up some of the supportive measures, and by supportive measures would mean things like making sure that we're using packing and splinting to close wounds and to reduce areas of potential blood loss. We make sure that we give tranexamic acid, and then moved to a plasma first approach using our lyoplas. And then a key part of that whole process of what can we do to preserve blood stocks would be to try and ensure that we get off universal donor as soon as possible, through using a process of pre-transfusion samples being handed to the trusts. So during the period of Amber Alert between August and July 24-25, this is a description of what our service undertook. So we transfused slightly fewer patients than we would have expected. Most of them were male, and 95% of them were trauma, which I think is fitting with what we'd expect from our national recommendations, and looking back through sort of things like this, the SWIFT trial, I think that fits with that patient population. 95% of them survived the hospital, and we gave in total 159 blood products, and of that we gave 58 red cells, and a range up to 6 of them, which of course implies that there's more than one resource attending any scene at one time, and also gave 100 units of lyoplas, and again up to quite large numbers of that. When we consider where we take our patients, so we're based roughly in the middle of that map, near a town called Devizes. The majority of the patients that we attend are blunt trauma, often suffered from road accidents, and we take the majority of our patients to that big red hospital in Bristol, which is Southmead and North Bristol Trust, and over that period of those 38 patients that we transfused, we took 28 of them to Southmead. There's 2 other major trauma centres that we often attend. Top right hand corner is Oxford, and bottom right is Southampton, and then we also take our patients down to the RUH occasionally, which is the one close to us in Bath, who also share our pre-transfusion sample details when we take patients to them. So thinking of the patients that we took to Southmead, of those 28 patients, 12 of them had further blood products given, or had red cells given, and further red cells given whilst they were in Southmead Hospital, and a total of 159 units of blood were given to those. The majority of those were the Group O patients at 143. Of those, 5 patients had more than 10 units of blood given, and 1 patient was given up to 50 units. Of those 12 patients, 4 of them had pre-hospital pre-transfusion samples taken, and 1 of them was rejected. But of those 4 pre-transfusion samples, that enabled us to use group-specific blood for 10% or 16 units of group-specific blood. And I think that shows a key importance of being able to take a pre-transfusion sample, and why it's important to use it, in that we can reduce the amount of universal donor blood that we administer to our patients, particularly further down the line in the hospital setting. So thinking about pre-transfusion samples, we would aim, and our standard audit practice and our standard KPI would be that 100% of all of our patients has a pre-transfusion sample taken or attempted. And looking back through our data, we have about 52% of our patients have pre-transfusion taken. And I asked my colleagues what's the reason behind that, and some of those reasons would be there was just so much going on, it wasn't possible to do it, or I couldn't get any blood, or actually I had to give blood before I was able to get any fluid out of the patient, and they were worried that it would contaminate some samples. And then there were other concerns sort of equally shared, that the local hospitals won't accept them, or the ED or the transfusion labs won't accept them, which means that people have a tendency not to want to take the samples if they don't feel that they're going to be used. I think Karen's now going to tell us around some further work that we've been doing.
Thank you, Ruben. So within North Bristol, we've always encouraged our local ambulances to take pre-transfusion samples wherever possible. But following discussions within the Transfusion Practitioners SIG, it became evident that practice was quite varied across the UK. So Ruben and I wanted to find out a little bit more, and we developed a survey which was circulated between July and August last year. It was sent to the medical directors of the UK air ambulance charities, and also to the transfusion practitioners via the TP-SIG. Of the 21 UK air ambulances, we received a response from 14 of them, and of those there were 43% of the charities which said they had a protocol for taking transfusion samples. This was 6 charities. The charities reported taking samples in between 10 and 80% of the patients which were being transfused. But disappointingly, only 2 of those charities said that their samples would be universally accepted wherever the patient ended up. The other 4 charities who took blood samples said it would be largely dependent upon which hospital received the patients and how they would manage those samples. There were 8 out of the 14 air ambulance charities who didn't have a protocol for taking samples. So when we asked them why not, 1 said that they had never had the need identified to them. One of them, during early discussions with NHS Blood and Transplant, deemed it not necessary. And there were several who quoted the difficulties with taking patients to the multiple destinations and the different sample acceptance requirements within these destinations. They were also aware of other crews who were taking blood samples but subsequently not being used. We asked if there would be a willingness for them to develop a protocol, and there was a 50-50 divide. There was 1 charity who was currently developing a protocol to allow them to do this. And on the other side of the coin, there was a charity who had previously an established service, which they withdrew because their local major trauma centre and local hospitals were not accepting the samples. And they really bounced the question back to us: is there a need identified for these samples to be taken? Their concerns related to a lack of universal acceptance of samples and the complications with the differing requirements depending upon the location the patient's taken to. In addition to difficulty taking these samples and the time required whilst on scene with the patient, combined with cognitive overload, possibility of forgetting to take the sample, and the introduction of errors in sample labelling, and the increased risk of needle stick injuries on scene. We then reviewed the responses from the transfusion practitioners, and we received responses from 32 trusts who, between them, acknowledged all of the UK 21 air ambulances as being their local charity. So we had a really good representation back. Of the 32 trusts which responded, 25 of them were receiving patients from air ambulances, and 12 of them were supplying the blood. But only 8 of them had an awareness that their local air ambulances may be taking blood samples, of which 6 trusts were reporting to receive, accept and process these samples, which was quite disappointing. We then focused our attentions on the major trauma centres because most of the patients are taken back to a major trauma centre. We had 14 responses back, and with England, that equated to a 46 response rate, which was really welcomed. Of the 14 MTCs, only 4 of them reported that they were aware they were receiving samples from the air ambulance charities, and only 3 of them were accepting and processing these samples. This really could demonstrate a missed opportunity when you consider that 8 of these major trauma centres, over 50% of them, were supplying the blood, and therefore had the potential perhaps to issue patient ID packs like we do in North Bristol, which would allow them then to accept the samples back and process them if the patients were to be brought back to their trust. The reasons for samples not to be accepted were largely relating to compliance with national guidance and local policy, and it was surrounding concerns over the pre-allocated patient ID or the use of the HEMS incident number as a unique identifier, combined with an absence of an NHS number and a relevant hospital number which would be accepted within their local system. Some trusts have a zero tolerance policy for hand-labelled samples. They must be electronically labelled. And one trust reported if the request form or the sample bottle was not the same as currently used within their trust, that would be seen as a reason to reject it. Additional comments from the TPs included a question around whether these samples are being taken by our ambulances, but perhaps the transfusion teams aren't aware of this. Maybe the samples are being disposed of in ED because the ED staff feel they're not compliant with the inpatient requirements for sample labelling. One transfusion practitioner questioned the potential for precious sample status. These samples are so important, not just for blood grouping, but also for antibody identification, and very often we're asked to provide them for toxicology screens with the police as well. So perhaps they could be stored and processed under concession. There was a lot of confusion and discussion regarding the requirement for 2 clean pre-transfusion samples, how these could be independently taken on scene, and what should happen if there was a mixed field post-transfusion reaction with 1 pre-transfusion sample. But there was overwhelming general support to accept these samples if they could be aligned with national policy and guidance. And I think some trusts also questioned what they could do locally to be able to support acceptance of these samples within their trusts. We had some really useful feedback from Fionnuala over in Northern Ireland. So within Northern Ireland, the air ambulance will carry 1 box of blood, and that 1 box will be only ever given to 1 patient. What would happen is a sample would be taken pre-transfusion, and the unique HEMS instant number would be recorded in the address field of the sample. It would then be signed, dated and timed by the practitioner from the air ambulance and brought in with the patient to the receiving hospital. At this point, once the patient is registered, the hospital identifiers would then be added onto the sample, and the sample could be sent to the lab with the request form and processed. Northern Ireland have a nationally approved request form, which is accepted in all hospitals, so this helps with the acceptance criteria. This system has been used for quite some time and has allowed a lot of samples to be accepted, but recently has become under review because the number used by the HEMS team is an incident number, and while the blood would only ever be given to one patient, there may be more than one casualty on scene, so there is potential for patient mix-up. So it is currently under review. So I think our survey findings has shown that there is quite varied practice around the UK. As Ruben showed with our paperwork, we issue patient ID packs to the air ambulances that we supply blood to. This allows us to fulfill our traceability requirements and also to accept these samples. But are we creating a bigger problem elsewhere by issuing the ID? Is this causing problems for sample acceptance in other hospitals who may receive these patients? On the flip side of that, we do also receive patients from alternative air ambulances who we don't supply blood to, and some of these will also carry our patient ID packs. So this will allow them to use this to take pre-transfusion samples, which we can then use to process the samples when the patient comes to us. So as part of this work, we would ask for consideration for a development of a national system within England, which allowed universal acceptance of these samples. It may require some or all of the elements below to be considered as part of that development. So would we need a pre-hospital specific paper transfusion request form, which could be universally accepted within all the hospitals because it would comply with national guidance? How can we allocate unique patient ID for the HEMS teams to use for their patients on the scene? Could that be some kind of centrally allocated, perhaps via NHSBT, nationally agreed scheme? And then once the patients arrive in the hospital, we need the ability to be able to allocate local hospital numbers, which can then be linked back with the HEMS ID to allow traceability of the blood components. There's a definite need for clarity on the national guidance regarding the sample acceptance of these pre-transfusion, pre-hospital samples. What should be the requirement for the second group? What should we do with management of mixed field? What happens if we're not able to take a pre-transfusion sample? Should there be consideration for historical groups held within local hospital systems, maybe not within the receiving hospital? And the consideration here, I think, is also for ongoing blood management. You've got the initial blood provision when the patient is admitted to hospital, but if you've got an indeterminate group, that could mean they stay on Group O blood for several weeks or for the whole admission. And finally, if we can agree a national system, we would need to develop a national training package and promote that with the air ambulance, ED, and the lab staff to ensure that everyone is aware of it and that together we can make sure more of these samples are universally accepted so we can switch away from, well, to group-specific blood much quicker. So what I would like to do now is hand back to Ruben, who's going to run through the case study, and hopefully that will lead some discussions for the question and answer. Thanks, Ruben.
Thank you, Karen. As I say, I'm just going to describe a case study from a case that we've been involved with. The next couple of slides, I'm just going to describe some clinical work. And so if you didn't want to hear that, please don't just mute me until I've come off these case study slides. There's a description of a case to follow. So there's a call to a 30-year-old male who's a motorcyclist versus a car. He's clipped a car and sort of not been knocked down the road and bounced off another car and a lorry, and the HEMS team is dispatched to that. They arrive on scene by helicopter after flying at about 160 miles an hour on a 5 to 10 minute flight, landing in a field and attend the scene. And they notice, and they describe in their notes, a reasonable amount of blood on the road, which I think the description is would read as quite a lot of blood. And they find a male lying on his back away from his motorbike with a open right pelvis, so a large wound on the right side of his hip, and with blood pouring out of that, a closed femur, thigh and ankle injuries, and obvious deformity to that leg. They identified that he's responsive to fluid, and what that described as is actually this patient, when he's got some blood volume, is conscious and alert and talking to you, and when he loses that blood volume, he becomes unresponsive. And these people are, feel really difficult and challenging and really quite emotive to manage. And the team identify that this patient is effectively dying. He's pouring all of the blood in his body out through his pelvis, and they identify that he needs volume, which we can provide some of, and surgical control, so he needs to go to a major trauma centre. And so they undertake some treatment, and that treatment is to pack the wound, stop the blood coming out, put a pelvic binder on, and splint the leg to try and stop any further bleeding happening. He has 2 grams of tranexamic acid, and then he's given effectively a blood transfusion made up of 2 units of O negative, 2 units of O positive, and 4 units of Lyoplas, along with calcium, antibiotics, ketamine for analgesia, and some sedation to manage the pain of moving him, and then being flown to the major trauma centre. And all of that happens from start to finish over the course of 50 minutes. There's a lot of in all of the speed and intent to treat. Unfortunately, no pre-hospital, pre-transfusion sample was taken. I asked the team what led to that, and that was partly around not having quite enough headspace to consider doing that when they were trying to focus on managing that patient, and difficulty with actually taking any blood samples from the patient, given that when they tried to put a needle in, actually no blood was coming out when they were putting their cannulas in. However, they did think that they would have the ability to have taken that sample after 1 or 2 units of blood products, so maybe an earlier sample when things had stabilised a little. When the patient arrived in the emergency department, I think he was best described as being too sick to stay in the emergency department, but too sick to leave. So they never managed to get him into the position to be able to leave our emergency department and go to theatre, which for our trust is a little journey down a corridor, up in a lift, and then another little corridor push. And so during that time of stability, he was given a further blood product, and that's described on those 2 pictures of handwriting on the right, with the first blood products being started at 10:58, and the last ones being finished at 12:43 in the emergency department. And he was given 19 units of red cells, 13 units of FFP, and a pool of platelets. Reading down that list of blood products, you'll see how challenging it can be to keep up with a 1-to-1 transfusion, particularly when you start to use up some of the blood products that are immediately thawed and available, and the time it takes to arrange for that. Whilst the blood products were being given, the surgical team attempted to stop the bleeding, and they placed internal packing and pressure into the pelvis, and one of the consultant orthopaedic surgeons actually placed their sort of most of their hand and forearm up into the pelvis to try and to stop further bleeding, but that was unacceptable. That just wasn't successful. And so in the end, the patient had a general anaesthetic, and then they undertook a theatre in our emergency department to open up the abdomen, find the aorta, our main blood vessel, down to the pelvis, and they clamped that over so that it stopped the bleeding. And only then were they able to transfer to theatre in a way that they were able to maintain his blood pressure and keep him alive. Over the next 16 days, he spent in intensive care and had 4 trips to theatre. Unfortunately, during that time, he had that leg amputated, and spent in total 6 weeks in the major trauma centre, and then was repatriated to his local trust. That was about a year or so ago, and he's now doing really well. He's neurologically intact. He's living at home with his family, a young family, and he's able to be a dad, and continue on his life because of that blood products and those blood transfusions that we're able to give him. Overall, he received 7 units of O negative and 27 units of O positive in hospital on day 1, and an additional 14 units of O positive in the following sort of 7 days. we were never able to find his blood product, and we took blood group and sent 12 samples within his admission. All of those were uninterpretable, and his local trust has since confirmed that he's AB negative and developed anti-CD and E antibodies. I think this demonstrates potentially some of the challenges around managing these major trauma hemorrhage patients. I think it describes some of the difficulties with taking a blood sample, but if we are able to get that pre-transfusion sample, significant numbers of blood products could be saved or prioritised by using group-specific blood earlier. And when we look at some of that blood products in the ED, you can see that perhaps it would have been challenging for any lab to have managed to give group-specific very quickly in that time with the volume we were using. But I would hope that at least half of that first day's worth of blood might have been reduced to group-specific blood. Karen, would you like to share our final conclusions?
Thank you. So I think it's quite clear that NHS Blood and Transplant will continue to face challenges meeting stock levels, particularly for Group A red cells. So these surveys, I think, perhaps present an opportunity to have a look at what current practice is. I don't think we have all the answers, but we've certainly highlighted some of the issues. And if there was potential for us to agree a national process for the acceptance of these samples and the ongoing processing, which will allow us to switch to group-specific blood, it would only help to preserve and protect the precious resource. I'd just like to say a huge thank you to everyone who contributed to our survey. It was only short and sweet, but it was really valuable. And it may be worthwhile going back to try and find out a little bit more about what's happening across the UK to see if we can build upon what is currently working and identify what isn't working, so we can then perhaps move forwards with this. Thank you very much to everyone for your time.
Thank you, Karen and Ruben. That was fascinating. We're going to swiftly move on to our second talk, and we'll take Q&A at the end. So if people have got questions, please put them in the Q&A so that we can pick them up at the end. Our second presentation is given by Fats Chowdhury. Fats is a consultant haematologist. She's jointly employed by NHSPT and Imperial College Healthcare NHS Trust. She's part of the national PBM consultant team of NHSPT, and she leads NHSPT on clinical business continuity. She currently chairs the NBTC Emergency Planning group, hence why these presentations, and she also chairs the Haematology and Trauma group. Now, Fats has actually videoed her presentation to just allow us a little breathing space. So thank you, Fats. Sasha.
Given the current climate we live in, emergency preparedness should be in the forefront of everyone's minds. Over the next 20 minutes, I'm going to highlight the important preparations that we as service providers of transfusion should consider. This is the overview of my talk. England has experienced a range of major incidents over the past 25 years. These include transport accidents, industrial disasters, fires, civil disturbances, and terrorist attacks. Highlighted in red are the incidents that have tested transfusion services most recently. And here listed are threats of a different nature that can have a much longer lasting effect on our laboratory services. The Civil Contingencies Act of 2004 requires all NHS organisation and providers of NHS funded care to show that we can deal with major incidents while maintaining services. This includes the transfusion community. Being prepared with good documentation is the first step in providing a response. The first NBTC EPRR guidance for hospital transfusion teams was published following the London 2005 bombings, where 4 coordinated suicide bombings targeted London's public transport, killing 52 people and injuring hundreds. The second guidance was published after the multiple Category 1 incidents occurring in quick succession in 2017. These tested NHS resilience with local, regional and national NHS command structures being repeatedly activated. The incidents spanned terrorism, fire and cyber attack. and demonstrated that EPRR must cover both physical and digital threats. The guidance was updated to incorporate the learnings from these events in 2019 with a further minor revision in 2020. The latest guidelines incorporates the lessons learnt from recent incidences, including power outage in Spain and Portugal, the DHSC-led power outage exercise and workshops last year on pandemic planning, recent disasters related to climate change, the Synovis cyber attack in 2024, mass casualty exercise led by NHS England in London last July, and NHSBT's internal exercises. Every guidance should start with definitions. Here are the main categories of incidents I will be discussing. Let's start with the key changes in the section on major incidents and mass casualty events. Since 2020, NHS England have developed two triage tools, the 10-second triage tool and the major incident triage tool. These can be used by all NHS responders in major incidents or mass casualty events. They allow rapid, reliable and reproducible triage of casualties. Priority 1 casualties are most likely to need transfusion support and as such should be prioritised to have samples taken for blood grouping. Priority 2 casualties may need later surgery and transfusion support. This generic command structure is based on the strategic, tactical and operational hierarchy. It is nationally recognised and accepted and used by emergency services. The principles of joint working support the development of a multi-agency response, helping to provide a structured response, which is especially important in the early stages of any incident where clear, decisive, robust decisions and actions are needed, often in a rapidly changing environment. The principles can be applied during any phase of an incident, including the recovery phase. The diagram illustrates an indicative sequence, however, these can be applied in different orders depending on the situation. The methane method is an established reporting framework which provides a common structure for responders and their control rooms to share incident information. It is recommended that this format is used for all incidents and be updated as the incident develops. For incidents falling below the major incident threshold, methane becomes an ethane message. Reviewing the hospital documents for major incidents, mass casualty events and EPRR will aid in the preparation of transfusion documents and the response. Depending on local facilities and specialism, your local emergency planning team will have determined the number of casualties that you can accommodate in the first hour or the first 24 hours. This is known as your predetermined capacity. Knowing the trust plans, training together provides a wider understanding of each other's priorities to provide a coordinated response. In 2017, we put forward that there was a benefit in putting a member of the transfusion team into the receiving areas. This aided communication and coordination of transfusion support. This slide summarises the key priorities in transfusion. Alternative modalities of communication should be planned for in case usual routes are unavailable. Undertake a quick internal stock inventory of not only your available universal components, but also products, consumables, reagents and cold boxes. This will help you determine if you have sufficient stock to provide for your predetermined capacity before requesting further blood components from NHSBT. Informing NHSBT that you have been stood up for an incident will activate NHSBT's internal system so that stock can be moved locally, regionally and nationally as required. Expect to receive samples from Priority 1 casualties. These should be processed urgently. Be prepared to receive samples from Priority 2 casualties later. Obtaining a confirmatory sample will enable moving to group-specific components thereby reducing the pressure on your precious universal stock. Depending on the time of incident declaration, additional staff may need to be called in the early phase. This should be considered in relation to expected workload and staffing needs over subsequent shifts and days and recovery phase. Measures to ensure staff well-being, both physical and mental, should be planned for. All documents should be dated, time-stamped and signed. Keeping a log of the names and signatures will help if these need to be reviewed later for forensic purposes. Stock should be released securely, maintaining the cold chain to clinical areas, and measures taken to ensure all components are traceable. If you have access to an electronic bedside system, this will help maintain traceability. Transfusion preparedness starts with ensuring your standard operating procedure and action cards are available for both clinical and laboratory staff. Pathology services and hospitals should practice drills regularly together to test the plans to ensure that all are aware of the wider picture and of each other's priorities. Drills should be undertaken at least 2 or 3 times per year. Where you're selecting and issuing blood components, if the blood group is unknown, males should receive O-positive red cells, and women of childbearing potential and children should receive O-negative red cells. However, if there is a shortage of O-negative, for instance in a mass casualty situation, and it would be life-saving to give blood, then it is permissible to give O-positive units to childbearing potential women and children, but there should be robust governance structures in place to ensure that these casualties are later followed up and managed appropriately and reported accordingly. Group A high titer negative plasma and platelets should be used for all unknown patients. If D positive platelets are given to women of childbearing potential, ensure that you have structures in place to identify them and to offer subsequent care with anti-D. Ideally, baseline blood samples for pre-transfusion testing should be obtained before transfusion of any components has taken place. Ensure the sample is labelled using a non-sequential unique patient identification number and gender as a minimum. A second confirmatory sample for transfusion should be taken as soon as possible and labelled independently from the first sample to confidently determine the patient's ABOD group. If an electronic process for labelling collected blood samples is available, this should be used to avoid the need for a second sample. The use of group-specific blood is normally recommended once the patient's blood group has been confirmed. There are advantages both to the individual patient, the wider population, and the blood supply chain if the patient can be safely transfused with group-specific blood components early. Hospital planning assumptions recommends P1 casualties taken to major trauma centres and P2 casualties to trauma units. However, this does not always happen due to multiple factors, and these include road closures, urgency of the need for surgical treatment, and specialist care. The literature supports the provision of 3 units of red cells per P1 casualty in the civilian setting. In the military, it's 8 units. Remember, in traumatic hemorrhage, the ratio of red cells to FFP is 1:1, and employing the second pillar and third pillar of patient blood management helps to minimize blood loss, promotes the use of tranexamic acid, the use of cell salvage, and restrictive transfusion. All of these PBM measures will help you support casualties, particularly when your universal component stock is limited. Transfusion support in the context of an incident must comply with BSQR and best practice as defined by NBTC, BSH, JPAG, and SHOT recommendations. Records should be retained for both regulatory and forensic purposes. Response and recovery are not two discrete activities, but may occur simultaneously. The recovery team should begin to plan recovery activities at the onset of the incident. As soon as the initial response phase is over, the focus should be on returning to business as usual or normality. This slide summarises what I've covered in the last few minutes. On activation, senior staff on site should assume responsibility for transfusion. All staff should follow their major incident action card. The hospital may be in lockdown due to terrorist attack. Staff should ensure that they have their identification badges on them, and these are worn at all times, especially if asked to come in to assist. The move of transfusion staff forward to receiving areas will aid transfusion support and appropriate sampling. Internal stock of emergency universal components should be undertaken with the assumption that 3 units of blood will be needed per P1 casualty. Consider thawing plasma, especially if pre-thawed plasma is not available. Ensure all decisions are recorded and measures are taken to maintain traceability. On stand down, transfusion staff should undertake local debrief within the transfusion service, but also attend the hospital hot debrief, which occurs within 1 or 2 hours of stand down, and the cold debrief, which usually occurs 2 or 3 weeks later. These debriefs help share learnings. Your guidelines and action cards may need to be updated with these shared learnings. On stand down, retrieve any unused stock from clinical areas and prevent wastage by sharing stock with other sites within your network or neighbouring hospitals. Review stock hoarding regularly over subsequent days until all services return to business as usual. Keep all documentation relating to stock and decision making, as this may be needed for regulatory and forensic purposes. This slide summarises the core business continuity threats in graphical terms, with important consideration for service provision listed below each key threat. In any instances where you are likely to experience loss of staff, whether this be due to infections or natural or man-made disasters, think about the minimum number of staff you need to provide a service. Remember that you can lose staff from the workforce to caring duties. This may be for children or elderly relatives. Anything that affects the wider population will affect donation of blood and can have an impact on the blood supply chain, as we saw post-COVID. Essential supply disruption could be to reagents, equipment, fuel or water. Think about your supply chain resilience. Have you got alternatives? Involve your commercial partners. You may lose buildings due to natural or man-made disasters such as fire, flood or explosions. Can you reprovision to an alternative site? How long would this take you? Do you have business continuity documents to cover how you would deal with infected biological material and decontaminating processes? I'll cover power outage in the next slide. But IT failures are common, particularly software defects, hardware failures. We all experience them from time to time. In 2024, we saw the wide-reaching consequences of a cyber attack on the Synovis pathology service. Thinking of that, have you got backup systems in place? Are they reliable enough to enable you to provide transfusion support? Have you got details of patients needing specific requirements or those with antibodies on an alternative platform? Do you have processes in place to be able to undertake manual ABOD grouping? In a national power outage, communication will be severely impacted. National communication may be through broadcast from Radio 2. Do you have airwave radios? How many? Do you have access to them? Would you be able to use them to communicate with your local hospital services? Is your laboratory on the priority list for generator power? How long would your generator last without fuel? Will there be power where your satellite remote fridges are located? Will you need to retrieve stock urgently to prevent wastage? Uninterruptible power supply should be available for all critical equipment which requires control power down, for example, blood grouping analyzers. Other critical equipment, for instance fridges, selected limbs terminals and plasma thorers, should be supplied by the backup generator. Non-critical equipment should be switched off to conserve power. In a national power outage, NHSBT would declare an immediate red alert, but may not be able to communicate with you. You may not be able to download the shortage plans, so having a printed copy available in the lab will allow you to follow the red alert actions in such a scenario. And finally, your staff, if they don't live locally, they may not be able to get into work if they're particularly dependent on public transport. What would you need to run a minimum service? When thinking about resilience and mutual aid in any of these scenarios, think about recruitment of additional and external staff to support manual processes. You should have plans in place for incidents which are prolonged beyond 1 or 2 weeks to provide support for existing staff to aid with double checking of processes to cover planned and unplanned leave. Providing or requesting assistance from another NHS organisation should be agreed on through local strategic command. The requirements, roles and responsibilities should be clearly set out in an SLA. NHSBT will not be able to provide services for routine grouping or cross-matching without a pre-agreed SLA. Every incident throws up elements that you will not have planned for. It is important to capture these from pathology and hospital debriefs and ensure that you have updated your documentation and put processes or pathways into place to mitigate for these. And finally, I cannot emphasize strongly enough the importance of looking after yourself and your staff both physically and mentally. Some staff may need help long after the incident. Make sure you have a system in place for supporting them. I've come to the end of my talk and covered all of these aspects. So what do you need to do now? If you go to the NBTC recommendation page and scroll down to the section where the Emergency Preparedness Guidance is published, you'll find a gap analysis tool. You can complete that for your organisation. I'd like to end by acknowledging the huge number of people who proofread this guidance and provided valuable feedback. In particular, my colleagues from EPWG, Celia and Mark, who not only provided me with feedback, but also many references which highlighted the benefits of looking after mass casualty victims and families in a single area. These aided conserving limited resources in the NHS, but also showed psychological benefits to the victims of incidents themselves. Thank you for listening.
First of all, if you could complete the evaluation form as a group, we'd be extremely pleased for you to do that. It helps us focus on what we're going to do next and what we want to look at in future years. If you haven't already done so and you'd like to attend the 2 other sessions, there isn't one next Wednesday because it clashed with a short meeting and we didn't want to interrupt that, but there are 2 more on Wednesdays in the lead up towards the end of May. Please do so. There's QR barcodes to do both on the calls. Thank you, Sasha, for putting them up. Thank you to our speakers again, Fats, Ruben and Karen. I think it's been an absolutely excellent session and a great start to our webinar series. Thank you.
Thanks, Julian. Thanks for co-hosting this. And I need to say a big thank you to Sasha, who did all the behind scenes, because we wouldn't have been able to run this without Sasha.
Yeah.
And Grace, who's helped us out today. So thank you, everyone. The next session is on the 20th of May, and it's on paediatric hemorrhage and major incident. I look forward to seeing you then.
Yeah. Thanks, everybody.
Cheers.